So my job is cut out because Dr. Dharmesh Kapoor covered quite a significant part of the thing so that it made my job very easy. So we should all remember that there is a difference between diagnosis and surveillance. So surveillance is when we try to look for some things which have not yet developed, but which we expect to develop, and then it is called surveillance. But suppose we find a round tumor in the liver or a round mass in the liver, and then we try to find out what it is, then we call it as the diagnostic part. The diagnosis of HCC has already been very nicely covered by the previous speaker. So when we talk about surveillance, we should know that surveillance will be helpful only when we know that the disease or the condition is present in a significant number of population. So when we talk about hepatocellular carcinoma, we can divide countries with very high incidence like China and Japan, with moderately high incidence, with intermediate incidence, and in low incidence. The justification of doing a surveillance program decreases as we move from a country of high incidence to a country of very low incidence. What is high incidence? High incidence are countries where it is more than 20 per 100,000 population. If it is between 11 to 20, we call it moderately high. And if it is below 5%, we call it as low incidence. And what falls in between this moderately high and low incidence is called the region of intermediate incidence. So if we talk about Southeast Asia, Asia Pacific, so we see that the commonest etiology, as already has been highlighted by the previous speaker, is hepatitis B and C related, though an increasing number of cases with alcohol-related HCCs have been recently reported. So when do we think that a surveillance is justified? So it is believed that the EASL guideline says that it is effective if it provides an increase in longevity of the life of a person by at least 100 days. Or the US ASLD feels that if the cost per year of life gain is less than 50,000 US dollars, it is considered cost effective. Other way around, any disease, and particularly HCC, which has a more than 1.5% per year incidence, will warrant a surveillance irrespective of the cost. So this brings us to the question, does surveillance program help for patient to detect HCC? So here I bring to the attention two very old studies, one in 2004. It was a population-based randomized controlled trial where they used surveillance ultrasound and alpha-fetoprotein measured every 6 months versus no surveillance. This was a study in Shanghai, close to 19,000 patients with current or prior hepatitis B infection, and these were patients regardless of the presence of cirrhosis. Though the adherence of the surveillance program was only 55%, yet it showed that this surveillance program decreased the mortality due to HCC by 37% in the surveillance arm. So this was a very promising result that brought into picture the role of surveillance in patients with HCC. However, another study from China tried to use only alpha-fetoprotein as a marker of HCC. This did not show any difference in the survival, and this study included only the high-risk male patients. After that, there has been many other small cohort studies which shows that doing a regular ultrasound without even doing an alpha-fetoprotein does have benefits as a surveillance tool. So who undergoes surveillance? So here I have tried to put side by side the EASL guideline, the ASLD guideline, and the APASL guidelines. So cirrhotic patient, Hep B, Hep C, alcohol use disorder or NASH related, if it is child A and child B, there is a consensus between EASL, ASLD, and APASL that all of them needs surveillance. In child C patient, however, the ASLD and the EASL feels that surveillance is worthwhile only if these patients are awaiting a liver transplant, whereas APASL feels that we can still continue surveillance because we can add life to these patients. In cirrhosis of other etiology, like primary biliary cholangitis or alpha-1 antitrypsin deficiency also, once there is cirrhosis, all the guidelines believe that we should do some surveillance. Coming to the non-cirrhotic patients, now a non-cirrhotic hepatitis B patients, the EASL feels that they are a high risk. We should use the page B criteria. So what is the page B criteria? It takes into account the platelet count. If the platelet count is more than 2 lakhs, it is 0 point. Similarly, if it is between 1,000 or 1 lakh to 1.9 lakhs is 1, and if below 1 lakh is 2. It takes into consideration the age and gender of the patient. If the total score is more than 18, it is considered as a high risk for development of HCC, which means there is a 17% chance that this patient may develop HCC at 5 years. If it is below 9, it is considered as a low risk for hepatocellular carcinoma. This is for non-cirrhotic patients. The ASLD feels that if it's an Asian male above 40 or an Asian female above 50, or patients who have a family history of HCC, they need to be under surveillance even if they are non-cirrhotic. And the APASL, in addition, includes that Africans above 20 years of age, even if they are non-cirrhotic, they should undergo surveillance. For hepatitis C with F3 fibrosis, how we detect this fibrosis is again a matter of debate because fibroscan is not a foolproof diagnosis. The recommendations are weak. Similarly, if there is fibrosis of any etiology, the recommendations are weak. But if it is an NFLD with F3 fibrosis, the APASL feels these are high-risk patients and should be put under surveillance. So if we talk about the controversial group remains the non-cirrhotic Hep B, the F3 fibrosis Hep C, and NAFLD with fibrosis. So most of the guidelines have a divided view, but non-cirrhotic Hep B, if they are in high risk, for example, the ASLD believes if there's a family history of cancer or smoking or concomitant alcohol use, we should be screening these patients. For F3 hepatitis C, we do not know when there is a transition from fibrosis to cirrhosis. So it recommends surveillance for patients if we have undergone a biopsy and there is a bridging fibrosis. Similarly, in NAFLD patients, 50% of NASH HCCs occur in non-cirrhotic, but it feels that we need to have a risk identification model so that we can do surveillance of patients with NASH irrespective of the level of fibrosis. So coming to how do we do surveillance, the EASL guideline believes that 6 monthly ultrasound is sufficient. The ASLD says it's 6 monthly ultrasound plus minus alpha-fetoprotein. They removed alpha-fetoprotein in between, but got it back. The APASL says it's a 6 monthly ultrasound and an alpha-fetoprotein. Ultrasound and alpha-fetoprotein are possibly complementary to each other. So I come one by one. What happens if we do a surveillance based on only an ultrasound? The false positivities are more with an ultrasound than with an alpha-fetoprotein. Why is it? Because in ultrasound, when we do an ultrasound examination, an ultrasound examination is considered to be negative if there is no focal abnormalities or we have definitely benign lesions like cyst. It is considered non-diagnostic if the lesions are below 1 centimeter and that doesn't look like benign. It is considered positive if we have a lesion of more than 1 centimeter. But we should remember that 20% of the ultrasounds that we do in the liver patients are considered as inadequate for surveillance because of either poor window or the poor visualization. A meta-analysis of 17 studies showed that surveillance ultrasound detected majority of HCC tumors before they presented clinically with a sensitivity of 94% and a specificity of 94% also. However, if we talk about early HCC, the sensitivity drops down to 63%. However, why we are still using ultrasound as a surveillance tool? Because it's easy to use, it's non-invasive, good acceptance by the patient, cost-effective, and it detects other complications like portal vein thrombosis. Disadvantage, it may be missing a lot of isoechoic lesions. It depends on the expertise of the operator as well as the quality of machine. And sometimes it is difficult to identify the lesions in patients with cirrhosis. Coming to alpha-fetoprotein as a surveillance biomarker. So it is considered the ideal serological marker for detecting HCC. Actually, alpha-fetoprotein is more of a diagnostic tool rather than a surveillance tool. The basis of the suboptimal performance, why we don't consider it as a surveillance tool, is that the alpha-feto level can be very much fluctuating in patients with hepatitis B and C during the course of the disease. And only a small percent, around 10 to 20% of patients in early stage of HCC present with raised alpha-fetoprotein. If we take an alpha-fetoprotein cutoff of more than 20, the sensitivity is 60% and the specificity is 90%. So a longitudinal change in alpha-fetoprotein may be more sensitive and specific. But the moment we take a higher cutoff of alpha-fetoprotein like 200, the specificity increases, but the sensitivity falls to 20%. So here it is, between 20 to 100, sensitivity is 61% and 86%. If it is 200, the sensitivity slowly drops to 49, the specificity increases to 98. If we take an alpha-fetoprotein cutoff of 400, the sensitivity is around 32% and the specificity, however, increases to 99%. So when ultrasound is added to alpha-fetoprotein for surveillance, it can detect an additional 6 to 8% of patients, but again, it will have a 7.5% of false positive rate. So this might lead to an 80% increase in cost for each small HCC diagnosed. So alpha-fetoprotein only used for surveillance has a false positive rate of 5%. Ultrasound used only as a surveillance has a false positive rate of 2.9%. Therefore, alpha-fetoprotein is still considered as an inadequate screening test for HCC when used alone without the presence of an ultrasound. Now there are some other that it will help us in surveillance. People have tried alpha-fetoprotein L3 fraction. It is more specific but very less sensitive. So there has been a proposed diagnostic model which is called the Gallant model, which includes alpha-fetoprotein L3 fraction, DCP, age, and gender. And it says that for HCC, the sensitivity is around 89%, specificity is around 86%. But if you see for early HCC also, the sensitivity is better than using alpha-fetoprotein alone, around 82%, and a specificity of 86%. People have tried investigational tools like a panel of microRNA, but these are not yet recommended outside of clinical studies. So why not use a CT or an MRI as a surveillance tool? Many people tell us that let us get a CT done in the first detection of the cirrhosis of liver. So as of now, there is no data to support the use of a CT or a dynamic MRI for surveillance. Against CT, the thing is of repeated radiation exposure, and the MRI is the cost. However, if the patient is on a transplant waiting list, CT and MRI can be used as an alternative because we need the CT for volumetric assessment and other findings. Also, people who are obese and where the ultrasonologist feels that there is a chest wall deformity or a significant amount of intestinal gaseous distension, which prevents us from getting a proper visualization, those are the cases where we need to do a CT or an MRI as a surveillance tool. So there has been a study comparing MRI versus ultrasound on 407 patients of cirrhosis, where this was used for surveillance. Among these 407, 43 patients developed HCC. 1 was detected by ultrasound, and 26 by MRI, 11 by both, and surprisingly, 5 were missed by both. What is the point against MRI is that it has a lower false positivity rate of around 2.6% when compared to ultrasound, but this needs to be validated in larger studies before we can push it to a guideline for screening of HCC. So how frequently do we do surveillance? So the ideal interval depends on what is the tumor doubling time of HCC and the tumor incidence in the target population. So most guidelines believe that the tumor doubling time is around 6 months. So they recommend 6 months as the interval at which we do HCC screening. Because the tumor incidence is very high in Japanese population, they feel that 3 months interval is what is to be done. And most of the Japanese guideline says we should do a screening at 3 months. There has been randomized study between 3 versus 6 months. They failed to detect any difference. However, when studies have been seen between 6 and 12 months, there has been definitely in favor of 6 months, which can detect a sensitivity of around 70%, whereas 12 months is only 50%. What is more important is what the previous speaker has also told is the recall policy. So if we have a nodule of less than 1 centimeter, which we are not sure, a close follow-up may be every 4 months for 1 year and 6 months thereafter, as suggested by the EASL guideline, or even a closer follow-up at 3 months, as suggested by the ASLD guideline, is required. Any nodules more than 1 centimeter will warrant further investigations when detected by an ultrasound. Now, this is something new which is coming up. Till now, we have been doing as a one-size-fits-all policy. Now, there has been a role of precision HCC screening, where we try to find out some baseline HCC predictors, whether these patients have a history of smoking, alcohol, family history, and we can use one of the HCC risk calculators. And based on this, we can classify them as high risk, medium risk, low risk, and very low risk. And then we decide whether the very low risk we may avoid screening. And then we may have different screening strategies like strategy 1, 2, and 3, based on which category they fall into. So for example, this is just a suggestion that suppose low risk patient may not go screening, very low will not go screening. Low risk patient may undergo a test with biomarkers or a panel of biomarkers. The medium risk may need an ultrasound plus biomarkers, and high risk we can do what is called an abbreviated MRI to use and detect HCC. It will cut down the cost and the screening time. So what are the novel biomarkers that have been developed? So we already have the Fujifilm WECO panel, which is a combination of AFP, AFP-L3, and DCP. And then we have the Gallard model, which I've already shown. The future is possibly roaming around liquid biopsy. These are not yet commercially available, which can detect the genetic and the epigenetic methylation changes. So there is a product under development, which is the OncoGuard liquid biopsy, and the Helio, which takes into consideration the circulating tumor DNA and also takes the Fuji WACO model with alpha-fetoprotein L3, and DCP. So we should be also trying, as I said, for novel screening tests like an abbreviated MRI, where you take only the T1 axial dynamic phases. And studies have shown that it is a similar sensitivity and specificity to a normal MRI. It is considered to be safe, non-invasive, and maybe half the cost of a normal MRI, and that would lead to cost effectiveness. So in future, we will possibly be shifting from a normal screening model to a screening model where it is based on risk, and as the risk increases, the effectiveness of the surveillance program will increase and it will be cost effective. As of now, in our center, we are still following the guidelines of using an ultrasound and an alpha-fetoprotein every 6 monthly. But any lesion that we find which is suspicious of malignancy, any lesions more than 1 centimeter, we definitely go for a triphasic MR, or if the patients have claustrophobia, we prefer a CT. And if lesions are less than 1 centimeter, we have a recall policy of calling them early. And if the lesions are more than 1 centimeter, we consider it as HCC unless until proven otherwise. So with this, I would like to end my discussion for today and would be happy to take any questions, I think, in the end with the panel discussion. Thank you so much.